Please start, sir. We are live.
Okay. Namaste and good evening, everyone. I welcome you all for today's webinar on Oncology Insight Forum second day 2. With immense pleasure, I would like to invite Dr. R.K. Chaudhary. He is a director and head of medical and hemato-oncology (BMT) in Metro Hospital and Cancer Institute, Delhi, and Metro Multispecialist Hospital, Noida, for the welcome and introductory note. The stage is all yours, sir.
Thank you, and welcome back to the day 2 of the Oncology Insight Forum. I really invite all the my faculties and the delegates, and I'm really thankful to them for joining on the time. So to begin with, I would like to invite my first speaker of today's and his close friend, and he's working with us with the Metro Hospital as the Director of Medical Oncology and Hematology and BMT at Metro Hospital, Faridabad branch. So I welcome Dr. Sumant Gupta, and Dr. Sumant Gupta is going to talk about the key takeaways from the SABCS. Dr. Sumant, please.
Thank you, sir. Thank you for your kind introduction. And so this topics given to me by Dr. Chaudhary, who is our mentor, is the takeaways from SABCS. So there are few abstracts. SABCS was a big meeting. We'll be discussing few abstracts which we thought are important, which we are thought provoking. So we'll discuss them. So the first abstract which I'll be starting with is Keynote 756. It is a phase 3 trial of new adjuvant pembro versus placebo in addition to chemotherapy, followed by adjuvant pembrolizumab versus placebo and endocrine therapy in high-risk ER-positive, HER2-negative early breast cancer. So we have always been talking about immunotherapy in triple-negative breast cancer. This is the first time we are talking in a ER-positive, HER2-negative subgroup, which is also the garden variety or the good variety. So let us see what this trial entails. Next one, please. So as we all know that ER-positive HER2 is a typically better prognosis than the other subtypes, but neoadjuvant chemotherapy is definitely given in some high-risk diseases. In Keynote 522, we have all seen the advantages of immunotherapy in the early TNBC. This is Keynote 756, which is an ongoing phase 3 study. And this is a subgroup or an interim analysis of the PCR rates in ITT population. So we are only going to discuss the PCR rates because in breast cancer especially, PCR rates have been classically or historically been said to be correlating to overall survival in later parts. Next one. So this is the trial design. It is an international randomized trial, multicentric, across continents, stratified by tumor PD-L1 status of more than 1 or less than 1, nodal involvement, positive or negative, ER positivity again, low or high, and the anthracycline schedule, both 2 weekly and 3 weekly were allowed. So patients were defined as high-risk grade 3 invasive ductal carcinomas from T1C to T3, T4, all of them, basically stage 2, stage 3, both were taken into this. The primary endpoints were PCR at the time of surgery, and the secondary endpoints, OS, will take a lot of time. And efficacy of PD-L1 in the CPS group more than 1 was also to be studied in the secondary thing. So if we see, it is quite a simple trial. They have started with the taxanes, reverse sequencing. So basically, pembro with the chemotherapy of 4 cycles. Initially, the pembro with the taxane, followed by the other anthracyclines. The surgery and then the adjuvant arm. Next one, please. So if we see the median characteristics, as in all good trials, they are well balanced. Next one. So patients with PCR, if we see the pembro arm, so the PCR rates, which was the primary endpoint, varied somewhere around 25% across the subgroups, whereas in the placebo, it was around 15%. So at the first interim analysis at 10 months of the patients randomized till now, the median follow-up of the trial has reached up to 33.2 months. So if we see, definitely around 10% advantage is there in the immunotherapy arm versus the non-immunotherapy arm. Next one. So this is again a very interesting subgroup analysis where they have taken the stage, the nodal stages, the region, and the PD-L1 scoring. So if we see in this clearly. The high nodal positivity is one clear indicator where pembrolizumab is a winner. If we talk about the regions, there is nothing major to be seen and a high PDL1 of more than 20 in this particular subgroup. So high risk, high PDL and nodal positivity, that is higher stage. So those three things have definitely come out in this particular subgroup. Next one, please. So if we see the PDL1, so PDL1 of more than 1 with a low ER, the responses of immunotherapy are much better. With a high estrogen receptor percentage, it is not that good. And in PDL1 less than 1, ER positive more than 10, it is one of the worst. So if you see this clearly, what it tells is that although we have taken a high risk HER2 negative HR positive subgroup, but this is the low HR kind of a subgroup, which I think might entail us to believe in longer thing that there are still subgroups which have not been classified, and this has more like a triple negative kind of a behavior. Next one. So this is the R0 resection rates. If we see the pembro versus placebo, again a rough difference between the R0 resection rates of around 10%. Next one. Side effects, nothing major in this. We know the immunotherapies, I think now after 8 to 10 years of using these drugs, most of us know that none of them has any major side effects. And usually, and as we learn from other cancers, addition of immuno to chemo does not basically make it very, very toxic. Next. So coming to the key take-home points in this particular study by the authors, in the patient with high-risk ER-positive HER2, neoadjuvant pembrolizumab plus chemotherapy improved the PCR rates versus placebo plus chemotherapy. That was 24 versus 15.6 across all arms. Improved PCR rate with pembrolizumab was observed across all subgroups, including region, disease status. This is what we have done. Greatest benefit, this is the most important of this, greatest benefit was observed in patients with nodal positivity at baseline, high PDL1 expression, and low ER values. That is, the estrogen receptors were less than 10%. So this is particular subgroup which has been the most efficacious, or which we can say behaves more like a TNBC or a very, very high grade ER positive HER2 early breast cancer. Next one. So coming to this, we had another study in the similar study, but this time it was a checkmate. This was a biomarker analysis of addition of nivolumab versus placebo to neoadjuvant chemotherapy and adjuvant endocrine therapy in high-risk ER positive HER2. So it's quite similar. Next one. So it is a phase 3 trial comparing addition of this drug in these high-risk ER positive HER2 negative subgroups. So the trial met the primary endpoints demonstrating the addition of nivolumab. Again, in this trial also, the R0 resection rates with the immunotherapy arms were around 10% more than that with the chemotherapy arm. And the nivolumab benefit increased among patients with PDL1 tumor. Next slide. So this is again the trial schema, quite similar to what we have seen in the previous one. And the similar study, but a different drug. And if we see the patient characteristics which were stratified, the stratification was quite similar to the previous one. Next one. Again, if we see the subgroup characteristics, it is well balanced. Next one. So if we see this, so they have now assessed it with the PDL basis. And if we see the right-hand side, the CPS score more than 5 had around 7 to 8% benefit, and the CPS more than 10, again this benefit could not translate. So basically the prevalence of PDL1 and still balance between the treatment arms, and with PDL1 SA, high OPAs were noted with the 28.8 CPS of more than 3. Can I have the next one? We'll discuss this again in detail. So this, yes. Can I have the next? So can I have the previous slide, please? Yeah. So this was again a similar study where the ER percentage and the PDL1 rates were confirmed, and benefit of Nivo was observed with low receptor subgroups. And they further on went on to say in there that with low progesterone receptor, even a higher version of ER receptor was also showing more responses. So this was something very interesting. Next one. So in the exploratory biomarker analysis of Checkmate 75L, the addition of nivolumab to the NACT was associated with greater clinical efficacy in patients with high risk, high grade ER positive, HER2 negative, who had higher levels of PDL1 expression or TILs and lower level of hormone expression. So I think quite a similar study, and I think with these two studies, maybe we might have more insight on these particular subgroups. Next one. This is the Alexandra trial. This is a TNBC trial. Again, this is more in lines with the Pembro trials in the TNBC subgroup, where this time atezolizumab was tried in the IM Passion 030. Next one. So, although the accelerated approval which was given to AT was withdrawn by US FDA, but still atezolizumab plus nab-paclitaxel is approved by other regulatory authorities for PDL1 positive TNBC. And this is a phase 3 IM patient trial with addition of atezolizumab to NACT. Can I have the next slide? So this is the trial schema, randomized open label phase 3 trial, where the patients with resected stage, that is adjuvant TNBCs with more than 50% node positivity, were divided into chemoimmuno versus chemotherapy arms. And the endpoint is again very interesting. They have not taken OS, they have taken a interim DFS in the intention to treat population. Next one. Baseline characteristics, well matched. Next, please. So if we see this, after median follow-up of 25 months, range 0 to 53, futility was declared for the primary endpoint of IDFS. And this was similar in all subgroups. Next. TRA is nothing different in both the subgroups. Next. Side effects, safety was quite similar. Next one, please. So investigators concluded that do not support the addition of atezolizumab to adjuvant chemotherapy in even early TNBC. So AT has not been that lucky in breast cancer. Initial approval was withdrawn on its own, and now this trial also has shown that AT somehow does not help in these particular TNBC subgroups. So the breast cancer approval, I think, now is a very, very distant future, because in both these trials, there has been no advantage of adding atezolizumab. Next one. So till now we have 2 positive trials, 1 negative trial of immunotherapy. Now we move to another interesting study, which is the HER2 Climb 02. It is the addition of it is the phase 3 trial of trastuzumab plus minus tucatinib in previously treated HER2 positive MBCs. Next. So tucatinib, we all know, is a HER2 directed TKI. Phase 2 HER2 Climb study showed the addition of tucatinib to trastuzumab plus capecitabine significantly improved the OS PFS. TDM1, again, we are well versed with the disease, with the drug, and current primary analysis of this interesting thing where TDM1 has now been clubbed to tucatinib in the HER2 Climb 02. They tried to evaluate the efficacy and safety of this combination in previously treated locally advanced and metastatic HER2 positive breast cancer. Next one. Trial design, as we discussed. Patients were taken on HER2 positive LA, MBCs, progression of prior taxanes, setting neratinib. So it was quite an interesting trial. And even brain mets was allowed. So I think this is more a trial which correlates with our day-to-day practice. So more interesting for us. Next one. Baseline characteristics, nothing much to discuss here. Next. So if we see the PFS, the hazard ratio has come out to be 0.76, although the median PFS is 9.5 versus 7.4. So statistically, yes, it is better, but again, around a 2.1 month advantage in a metastatic setting, even this might be an important landmark. Next one. So this is again in pre-specified subgroups where they have tried seen the efficacy even in the brain mets people and in more than one line treated patients. So quite an interesting trial again against many geographical regions, more of a pan-continental trial. Next one. So if you see the age, the elderly have a better hazard ratio. Race, hazard ratios are quite similar. Stage of diagnosis again, and prior pertuzumab treatment again does not change much of this. So overall, the hazard ratio has been 0.76 in the PFS arm. Next one. Brain mets patient, again, the hazard ratio is very interesting, and it might be the one of the subgroups where we might be more interested in adding another oral HER2 blockade. Next one. Coming to the secondary endpoints, if we see the events in the median OS, the hazard ratio has not been reached. It is 1.23, which is not acceptable. Next one. Safety-wise, nothing major, no major alerts. Next one. Hepatitis, diarrheas, this is all as per expected with the drug individually. So the addition of drug has not significantly changed anything much. Next slide, please. So this is an interesting trial of addition of double HER2 blockade. Median PFS hazard ratio definitely achieved, but OS data till now is not mature enough, or we can say that OS data is not yet interesting enough. So for my personal take on this particular trial, brain mets positive, previously heavily treated, HER2 positive breast cancer, addition of a second drug might be something which we might discuss with our patients on a day-to-day basis. Next one. So coming to the another interesting study, which is the DFS analysis of the NATALI, which is the phase 3 trial of Revo plus NSAIs in HER positive. So I think in most of the meetings now, every 6 months, we are getting new and new data of Revo. Next one. So in this interim analysis of phase 3 NATALI trial, adjuvant Revo plus NSAIC showed significant improvement of IDFS versus the NSAI arm alone. So I think this is something which we have experienced, which we are understanding, and this is just a addition to our daily clinical practice and our beliefs. Next one. This is the randomization of the NATALI trial, which I think most of us have seen. The next one. Baseline characteristics. Next one. So at 3 years, the ribociclib plus NSAI IDFS is 90.7 versus 87.6. Hazard ratio, although significant, month-wise, not a major game changer. If you see the 2-year IDFS also, it was only 2.5 months, so which is quite consistent in the 3rd year also. Next one. So this is by the key sites, the events. Next one. Next one. Can we come to the conclusion slide? We'll discuss that. Next. The previous one, please. Okay, so coming to the conclusion, in this final IDFS analysis, as pre-specified, 78.3 patients were no longer receiving ribociclib by data cutoff. IDFS benefit with ribociclib plus NSAI was consistent across pre-specified patient subgroups, and no new signal observed at the 3-year ribociclib regimen. So I think this is again which goes in favor of ribo, that it is a safe drug and a very well tolerated drug. So thank you, Dr. Chaudhary, for giving me this opportunity, and thank you, organizers.
Thank you, Dr. Sumant. It was really a wonderful talk, and you could have done the justice to the topic allotted. It was wonderful and informative listening to you. Thank you once again.
Thank you, sir, for giving me the opportunity. Have a nice evening.
Right. Thank you, sir. So for the next talk, I would like to invite again my dear friend Dr. Pankaj Goel from the Rajiv Gandhi Cancer Institute. And Dr. Pankaj Goel is a senior consultant in medical oncology at Rajiv Gandhi Cancer Institute, main branch Rohini. And he's going to talk on the optimal sequencing of the therapy in metastatic HER2 positive MBC, which is nowadays talk of the town. Dr. Pankaj, please.
Yeah, thank you, sir. Thank you for giving me this opportunity. I think I'm audible and my screen is visible. Am I audible?
Yes, sir. Yes, sir.
I'll just share my slides. Yeah, so thanks a lot. And it's an interesting topic because we are having newer and newer drugs available now for this HER2 positive CA breast. And this is a practical guide how to select, sequence, and optimal use of these HER2 target therapies in HER positive metastatic breast cancer. So the goal will be to augment our knowledge of the current and evolving role of HER2 target therapies, equip us to optimally integrate these HER2 targeted therapies. So this is the guided research and advocates to scientific partnership presentation in the local advanced breast cancer. So we will discuss how to overcome existing challenges. So current standard of care and best practice of selection and sequencing of HER2 target therapy will be the topic. We know we have so many drugs available with us. Started with trastuzumab, then lapatinib, and then we have TDM1, we have TDXD, we have pertuzumab, and many drugs which are still not yet available like tucatinib, margetuximab. So we have so many drugs. So there's always a challenge that how we should sequence these drugs so that we can have maximum benefit out of these treatment sequencing. So I think still whatever data we have, first line therapy without any doubt remains a pertuzumab and trastuzumab based therapy, that is PTCH regimen what we usually use. So it started with the Cleopatra trial, but we are very well aware of it was a advanced stage a trial in which it was compared with the single HER2 targeted therapy versus dual HER2 targeted therapy, and it was seen that it drastically improved the PFS and OS. So we can see that the PFS, median PFS with this drug was 18.7 months, and landmark OS 37% improvement. Median OS improved to 57 months, improving by around 14 to 18 months, so for 16 to 17 months in the patient without who did not use pertuzumab in first line. Second line therapy, I think now we have a stronger contender. First line therapy, it was always trastuzumab plus minus pertuzumab. Second line, it used to be TDM1. Still, I think it remains TDM1 because of the cost of the TDXD. But if we keep aside the cost, then I think TDXD is the preferred second line option. We know that TDXD is a topoisomerase 1 inhibitor, while TDM1 is a microtubule inhibitor. Tumor selective cleavable linker is seen in TDXD, unlike TDM1, and a bystander anti-tumor effect when the cell is lyse and the drug is taken up by the bystander cell, that is seen in TDXD, unlike TDM1. So this is the trial, Destiny Breast 03 trial, in which they had taken the unresectable metastatic HER2 positive breast cancer patients who had been previously exposed to trastuzumab and taxane. And if they have received in adjuvant setting, then it is 6 months of therapy. They were certified either to TDXD or TDM1. Primary endpoint was PFS, secondary endpoint was OS. So here we can see that the PFS improved from just 6.8 months. It was 8 to 9 months in the previous study. It was 6.8 months here. Improved to 28.8 months. So you can very well understand that it increased 4 times. The PFS, that was a drastic improvement in the PFS. And we can say that hazard ratio was 0.33, very significant. Along with that OS, it was not reached in either arm, but hazard ratio, if you see, it was 0.54. So we expect even a OS with this drug TDXD when we see PFS has increased by more than 4 times. Next slide. So evaluation of PFS after trastuzumab and taxane. So we see that initial median PFS, what we have seen with various drugs, was capecitabine 4.4 months in second line, caplap or cap trastuzumab or TDM1. They all were hovering around 9 months. Then we had some data with capecitabine and pyrotinib, not readily available, 12.5 months. And we see this TDXD standing tall with 28.8 months of PFS. Then we had Destiny 09 study, in which this was compared head to head with the taxane plus HP regime, which is standard of care, compared with TDXD plus pertuzumab. So primary endpoint was PFS. But how will so this was a Destiny Breast 03 trial in which we see that in the TDXD arm, any grade side effect were 27%, and TDM1 it was 19.5%. And apart from that, if we see that the TDM1 was more often creating a derange of SGOT, SGPT, that is 41%. And when we see that usage of TDXD, they were more responsible for weight loss, 22.6%. These were the different in the side effect profile. So any grade side effects were more with TDXD as compared to TDM1, but then grade 3 side effects we see they were more or less same, 0.8 versus 0.4%. So adjuvated drug-related ILD was similar in like in other MBC trials. With longer treatment exposure, pneumonia rate increased from 10.5% in the PFS interim analysis to 15.2%. The overall grade 3 events were very less. There was no associated drug-related grade 4 or 5 events. So this is the way detecting and managing the TDXD related ILD. First, we have to screen the patients that they are not having any underlying ILD. Then the fundamental diagnostic tools for ILD remains the CT scan, high resolution CT scan, and they have to be repeated every 12 weeks. And ILD involves teamwork, which includes educating patients that if they have breathlessness, they have to report early. Suspend treatment if the patient is having a ILD. And steroids are the mainstay of treatment if the patient is developing this. Third line therapy. So this is the Destiny Breast 01 phase 2 single arm study, response of trastuzumab deruxtecan. This was after the first line therapy, second line TDM1 when it was used. So we can see that the number of patients had a deep response. So Destiny Breast 02, they were patients who were HER2 positive patients, documented radiographic progression, previously treated with TDM1, and stratification factor was hormone receptor positivity or negative and exposure to pertuzumab. They were randomized to treatments of physician choice or TDXD. Then again, we see the PFS, it improved from 6.9 to 17.8 months. So mind it, this is the third line study in which where we had seen that with the second line, we had around 28 to 32 months of PFS, it was 17.8 months in the third line. Similarly, the OS, if we see, there was a wide gap between these two arms, hazard ratio 0.66 and p-value 0.0021. So as compared to treatment physician choice, which was 26 months survival, TDXD had a survival of 39.2 months. So tucatinib is another drug which is highly specific to HER2 receptor compared to lapatinib and neratinib, which also binds to other HER2 receptors. So in the NALA trial, phase 3 trial of neratinib plus CAPE versus lapatinib plus CAPE, we had seen there was a marginal improvement in the PFS. However, OS was not significantly improved. So the PFS improvement was just 2.2 months. HER2 client drug tucatinib plus trastuzumab plus CAPE. So this was a triple drug regimen which was compared with a double drug regimen, we can say, where we had used this HER2 metastatic breast cancer who had previously been exposed to trastuzumab, pertuzumab, and TDM1 in the second line. And they were randomized either to placebo plus trastuzumab or tucatinib plus trastuzumab plus CAPE. So endpoints were PFS, primary endpoint, secondary endpoint was OS. And they were stratified on the basis of brain metastasis. So HER2 client study, we see that the PFS had improved, hazard ratio 0.57. Improvement was from 5.9 months to 7.6 months. OS, if we see, again, it is showing a significant OS improvement as well. 19.9 months median PFS was to 24.7 months. At around 2 years, 51% patients were alive as compared to 40%. So we can think that this was a quite effective drug, and it was quite effective in the brain mets patients. So we see the HER2 client 2 study in which they had studied these patients with unresectable locally advanced metastatic HER2 positive patients with progression after trastuzumab and taxane. They were compared either to tucatinib plus TDM versus TDM1 alone. So the results are yet to be released. But if we consider a case like a 62-year-old woman, newly diagnosed metastatic breast cancer, and presents with ERPR positive, HER positive disease, who 4 years back underwent BCS, and then lost to follow-up, did not receive any further treatment, went to emergency department with liver enzymes which are elevated, and still the patient is ER positive, HER positive. So I think in this type of cases, we can very less, and this happens to be a first line study. So probably we'll go for pertuzumab plus trastuzumab plus combination if the patient can afford. And is the overall prognosis for new patient HER2 positive? So I think the overall prognosis, the where few years back it was dismal. Now with the HER2 client study itself, we had seen the survival was improved to around 4.5 months to 4.5 years to 5 years, and with the TDXD we expect even to be better. So it's also become more or less a chronic disease. And so I will skip the case presentation. So another thing is what to do with a patient with brain metastasis. So brain mets are quite common in patients with HER2 positive breast cancer patients, and we see that around 1/3 of the patients will have brain metastasis in the course of their treatment, 20 to 30%. Surgery in case of very limited cases, otherwise usually the radiation is the treatment of choice, which is to be used in the patient. Surgery, again, we can have combination of surgery and radiation. And systemic therapies, now we have various systemic therapies, but I think preferred first line still remains pertuzumab, trastuzumab. In second line, if you do not have TDXD, then TDM1 remains a good choice. If TDXD there, that remains the second choice. In third case, I think we all agree that tucatinib, lapatinib plus capecitabine will be the preferred choice in the third line. So then we also can discuss the Cleopatra trial in which pertuzumab was introduced with trastuzumab plus docetaxel based combination. Then we had Destiny Breast 03 trial in which unresectable metastatic HER2 breast cancer patients were taken, and patients who were exposed to this trastuzumab plus taxane in first line, they were exposed to TDXD versus TDM1. So this is, I think we have discussed it, that the PFS improved from 8.8 months to 28.8 months. So without brain metastasis still should be emphasized in this study. As we can say, in the patient who had brain metastasis, in those patients also TDM1 improved the PFS from merely 3 months to 15 months, hazard ratio being 0.25. And in without brain metastasis also hazard ratio was 0.30, and we see the both the graphs were wide apart. Intracranial response, we can see a very good intracranial response with a complete response in 27% cases and partial response in 36% cases. So overall response improved from just 33% to 64%. So this was a pooled analysis from all these Destiny studies in HER2 positive breast cancer patients. And here we can see that the patient who had been on the TDXD, they were having much better response. Complete responses were seen in 25 to 28% of cases, and partial response in 15 to 16% of cases. When compared to the other patients, other therapies, it was 12% or 27% only. So this was a pooled analysis. Treated stable brain mets patients, 0.59 was the hazard ratio, and untreated active brain mets patients also we see, as compared to 4 months PFS, it improved from 8 to 18.5 months. Hazard ratio was again very impressive, 0.1919, and we see the graphs are much more wide apart. So this also gives a school of thought whether really need to address the brain metastasis if they are asymptomatic, or probably we can rely on their efficacy. So TDXD demonstrate trend towards prolonged CNS PFS over comparator, with a noticeably greater advantage for patient with untreated or active brain metastasis. So efficacy of TDXD drug use, the dosage is 5.4 mg per kg. So in best CNS response, as we can see, the overall response rate for as high as 75%. So PFS 14 months in these 13 patients. So then we have this other trial, TDXD, where multicentric open label study in which patients with brain mets were taken in various cohorts, and they were treated with TDXD based therapy. So efficacy we see then the cohort 2, where they had asymptomatic brain metastasis. The overall response rate was around 50%. Then we have similar studies for brain metastasis, which are still under trial, like Destiny Breast 03, Rosette, which is a retrospective study, Tuxedo phase 2 study, and HER2 client study. This also we have discussed, tucatinib, trastuzumab plus cape versus the double agent trastuzumab plus cape stepping based therapy, and where we had seen that the PFS rate was improved, but the overall response rates, if we see the intracranial, it will improve from 20% to 47.3%. And updated OS in the patient who had brain metastasis, it improved from 12.5 months to 21.6 months. P-value being very significant at 2 years of follow-up. 25% of patients were alive in the double agent therapy, while with tucatinib-based therapy, 48.5% patients were alive. Apart from that, these are the ESMO guidelines where we have active brain metastasis. If the local treatment is not indicated, then we can go for some effective therapy which has intracranial response as well. If local therapy is indicated, it can be a WIT. There are many metastases in the brain, or patient go for SRT or plus minus resection. And if the patient is having no brain metastasis, then we have to go ahead with the therapy. So this is the second line therapy. So in second line therapy, we can use TDXD, but if that is not available, then we can very well go ahead with tucatinib. And if the patient is having no symptomatic metastasis, then we can do away not giving the local therapy. So oligoprogressive disease occurs following an initial response to systemic treatment where disease progression only occurs in a limited number of sites. Like in this case, if the patient is having a CNS metastasis. So CNS isolated progression can be there in 13% of cases. So there always remains a question whether we want to change the therapy or we can give a local therapy and continue with the same therapy. So we have different thoughts of opinion. Like in local strategies, people think that will have neurological symptoms, and more of SRS will be given in less than 10 lesions. Big lesions are bad localizing signs. And in favor of systemic therapies, we see that patients having asymptomatic disease, we have very good drugs which have intracranial penetration. So if patients having small metastasis, asymptomatic, we still have good drugs in the hand. Then we can wait and watch and change the therapy. So incidence of brain metastasis in patient with HER2 positive is increasing. Individualizing case by case is always important. TDXD has shown activity in CNS mets with promising efficacy in several trials, around 50 to 70%. Tucatinib has shown CNS activity in a randomized phase 2 trial. No head-to-head comparison with TDXD. And standard clinical trials of patients with HER2 positive brain mets is an unresolved need waiting for the results of Destiny Breast 02 trial. With that, I'll conclude, and thanks for the patient hearing. If there are any questions, then we can discuss.
Thank you, Dr. Pankaj. If there are any questions, we can take one or two questions. There are no questions. Then thank you very much, Dr. Pankaj, for such a lucid and informative talk. Thank you once again. So we'll move on to the next talk, and which is by Dr. Ankur Nandan Vashne from the Medanta Hospital, Gurugram. Dr. Ankur is medical oncologist at Vedanta and is going to talk about the TNBC, the diversity and its clinical implications. Dr. Ankur, please. डॉक्टर अंकुश का बात हुई
सर
Sir, Suhas sir is here to give the talk.
Right? Dr. Shuhas is there?
Hi, sir. Good evening.
Hi. Hi, good evening. So I think Dr. Ankur is not available, so we'll move on to the next session. And for that, I would like to invite Dr. Shuhas Shingla. He's the Director and Consultant Medical Oncology and Hemato-oncologist from the Rohtak. And Dr. Shuhas is going to talk on the decision making in ovarian cancer, impact of mutations and outcome. Dr. Shuhas, please.
Yes, sir. So I'm unable to share my screen.
So tag team, please help him.
Sir, click on share screen button.
Hold on, dear. Okay. I think my screen should be visible by now.
Sir, click on share screen button, sir.
Are the slides visible?
No,
He
sir.
is not visible.
Not visible. Okay.
Sir, back to Zoom screen.
Anybody from the tag team, please will share the slides.
हेलो निशांत सर आपके पास स्लाइड है
Are the slides visible now? Are the slides visible now?
नो सर
Nishant, can
Sir,
you share the slides?
yeah. Nishant, can you share our slides? Yes.
Okay, fine. We can start.
No. Oh.
Shall we start?
Yes, sir. You can start, sir.
Okay. So, good evening, everyone. Today we are talking about very important topics, and one of those important topics is decision making in ovarian cancers and impact of mutations and outcomes. Thank you for having me on the platform. Next slide, please. So, ovarian cancer worldwide. So, it's the seventh most common cancer among women, with more than 3 lakh ovarian cancers being identified in 2020, and more than 2 lakh of them actually you may consider died because of this cancer. It is 3 times more lethal than the breast cancer, and has got the highest mortality rate in Asia, which is I think much higher in India. Next slide, please. So now let's talk about some stats from India. India has got the world's second highest ovarian carcinoma incidence, the third most common cancer among the Indian women. The projected incidence in India for 2020 is around 43,886, which is pretty high. A leading cause of cancer deaths in Indian women, with more than 20,000 of the cancer deaths being attributed to this cancer. Incidence rates increases from the age of 35 years and peaks between the age of 55 to 64 years. Next slide, please. So incidence of ovarian cancer is estimated to be increasing in India. Recurrent ovarian cancer develops in more than 80% of women. 75% of them present with advanced stage, that is stage 3 or stage 4 disease. Despite of surgery and chemotherapy, most of the patients will relapse within first 2 years of the diagnosis. There is no effective lab test available to actually detect it early. So now, as the topic is the mutations and the treatment. So mutations in ovarian cancer. Next slide, please. So we are all very well aware about the BRCA1 and BRCA2 mutation. BRCA1 mutation occurs in approximate 25 to 65 25 to it increases the risk of this cancer by 25 to 65%, and BRCA2 mutation leads to increased risk of 15 to 20%. 1 in 4 patients with advanced ovarian cancer have BRCA mutation detected on tumor testing, and 1 in 2 patients with advanced ovarian cancer have HRD. And these are kind of tumor suppressor gene which are actually known to decrease the propensity to develop a cancer. Next slide, please. So HRD, what is HRD? It is basically homologous recombinant deficiency, as we can see in this graph. So there are multiple genes which are involved in the same. So most of them which are includes BRCA1, BRCA2, CDK12, RED15, and many others. Next slide, please. So this is actually how now we are going to treat our patients, and there is coming up roar about that the cancer should not now be recognized by the organ of origin but by the by its mutation. Thou I don't agree with the same. Next slide, please. So ovarian cancer treatment. Next slide, please. So if we talk about ovarian cancer treatment as has been depicted in this flow chart, it's pretty easy to understand. Ovarian cancer, we have to look for the surgical assessment. If the patient can be debulked to R0, then yes, obviously surgery is the way to go. But in most of the patients where we get encounter in advanced stages, so we usually land up with neoadjuvant chemotherapy, and we look for when the patient is debulkable to R0. And the patient is debulked to R0, then if there is no residual disease, then platinum with paclitaxel chemotherapy, IVIP with plus minus PARP inhibitor. And if the residual disease is more than 1 centimeter, then platinum plus paclitaxel chemotherapy plus minus bevacizumab followed by a maintenance. So, and then generally, as we have already seen in the previous slide, almost 80% of the patients do progress. So after progression, if the platinum, it's a platinum resistant disease or a platinum sensitive disease, surgical assessment has to be done. Single agent chemotherapy can be used in platinum resistant diseases. For platinum sensitive, it is better if we can provide we can do a surgery and then we re-challenge with platinum and taxanes or platinum gemcitabine liposomal doxorubicin bevacizumab with plus minus of PARP inhibitor maintenance. Next slide, please. So what are the guidelines? What are the recommendations? Next slide, please. Coming on to the NCCN guidelines, as we can see from this flowchart, very beautifully depicting that if bevacizumab has been used and if not has been used, then what is to be done. BRCA1, BRCA2, generally we nowadays are preferring to get it done or get it tested on for the germline or somatic mutations. Usually we go for germline ones. And if we find somatic ones also, then there is a data for using PARP inhibitors in maintenance therapy, even after achieving a complete or a partial response. So as we can see, we can obviously use PARP inhibitors even if the bevacizumab has not been used in this subset of the patients where BRCA1, BRCA2 are even wild type. In those cases, rucaparib and niraparib can very well be used. In patients where bevacizumab has already been used and where HR deficiency has been proven, there bevacizumab with olaparib, and if it is proficient, then bevacizumab alone is the way to go. Next slide, please. So now the platinum sensitive disease, if we are talking about complete remission and relapse after 6 months after completing of the prior chemotherapy, radiographic and or clinical relapse, consider secondary cytoreductive surgery, and then a combination of a platinum based chemotherapy preferred for the first recurrence, followed by a maintenance therapy if PR or CR. Useful in certain circumstances to continue bevacizumab if previously treated with chemotherapy plus bevacizumab. And if there is a biochemical relapse, which is very important, that CA125 is rising, but you are not getting anything on radiology, then delay the treatment under the radiological, radiographic or a clinical relapse is present, or immediate platinum therapy, which generally most of the physicians don't go for. And this is followed by PARP inhibitor therapy. And if not previously used, then if previously used, then we should go for otherwise. Next slide, please. So this is the mechanism of PARP inhibitors. Please keep on clicking. So PARP
is a superfamily of 17 enzymes which are involved in DNA repair and maintaining genomic stability. PARP1 accounts for approximately 90% of the entire PARP activity. Next slide, please. BRCA1, BRCA2 deficient cells are actually prone to these PARP inhibitors. In the way diagram has been shown, what happens is PARP is actually responsible for single repair of the single strand breaks. If the PARP inhibitors are utilized and PARP is deficient in such a scenario, in that case, it actually converts into a double strand break, uh, resulting in a cell death via mechanism of synthetic lethality. Next slide, please. So, what are the landmark trials in ovarian cancer? Next slide, please. Olaparib in ovarian cancer. Next slide. Maintenance olaparib in newly diagnosed ovarian cancer with BRCA mutation. Solo 1 7-year follow-up. A brilliant study which actually led to incorporation of olaparib. So 300 mg twice daily versus placebo. 2:1 was the randomization up to 2 years or until progressive disease. Primary and updated analysis. Olaparib significantly improved the investigator assessed PFS. Primary analysis PFS could not be reached with olaparib versus 13.8 months with placebo. An updated analysis conducted after 5 years of follow-up, median PFS was 56 months with olaparib versus 13.8 months with placebo. Next slide, please. So this was a beautiful graph depicting the difference of overall survival with Solo 1, and their median OS couldn't be reached with a hazard ratio of 0.55, thus providing a 45% reduction in chances of death and a significant p-value of 0.0004. Next slide, please. So this was the time from randomization, random assignment to first subsequent therapy or death. So if we can see that here also olaparib could make a significant difference. Next slide, please. And if we look for time from random assignment to second subsequent therapy or death, there also olaparib could make a huge difference with a hazard ratio of 0.5, meaning a 50% reduction. 56.9% of olaparib patients versus 32.5% of placebo patients were alive and had not received a second subsequent therapy even after 7-year follow-up, which is huge. Next slide, please. So final results from Paola 1 maintenance olaparib plus minus bevacizumab, which is now becoming the standard way to go. So where again 2:1 was the way in this patients with newly diagnosed ovarian cancers and PR or CR after upfront or interval surgery, standard platinum taxane based chemotherapy. More than 3 cycles of bevacizumab should have been utilized. Olaparib 300 mg BD for 2 years with bevacizumab 15 mg per kg 3 weekly for 15 months versus placebo. A primary endpoint was PFS. Next slide, please. So final results for Paola 1 olaparib group, we can see that the investigator says PFS was 22.1 months. Placebo group it was 16.6 months. Hazard ratio was 0.59. Thus a 41% reduction in chances of progression. Next slide, please. So final results from Paola 1 maintenance olaparib plus minus bevacizumab in advanced stage ovarian cancer. Olaparib group 26.1, placebo 18.3, hazard ratio of progression or death was 0.63. Again, a 37% reduction in chances of death. Next slide. And now coming on to the OS, if we see, it could not create a lot of difference, but yes, PFS was highly significant, which was a primary endpoint. Next slide, please. So, but when OS was looked in HRD positive subgroup, it was found to be useful, and hazard ratios were 0.62, resulting in a better survival, where especially in HRD positive subgroup. Next slide. Paolo 1 again PFS in HRD positive subgroup, 40 almost more than 50% reduction in chances of death with in chances of progression with use of olaparib with bevacizumab. Next slide. So now if we talk about OS by HRD status, BRCA mutated, if we can see that the hazard ratios were 0.6, and for HRD positive excluding BRCA mutated, the hazard ratios were again 0.71, and subsequent PARP inhibitors were utilized in almost 9.3% patients who were receiving olaparib with bevacizumab compared to 41.8% of patients who were on bevacizumab alone. HRD negative, again, the hazard ratio was not at all good. Next slide, please. So final results from Paula 1, again, adverse events of special interest in final OS analysis. So as we can see that olaparib with bevacizumab results in a good amount of MDS AML or of approximately 1.1 versus 0.4 when primary PFS analysis was done, and after 1 year the number increased slightly as compared to the previous numbers, but the difference became slim, and as we progressed the numbers were higher in the patients where actually olaparib was not used, and the similar trend could be seen with the new primary malignancies and pneumonitis, ILD, and bronchiolitis. Next slide, please. Solo 2 trial, another trial where olaparib maintenance was used in platinum sensitive BRCA mutated recurrent ovarian cancers. And here 295 patients were randomized in 196 to 99. And olaparib was used as the same at the same dose. Patients were who had serous ovarian cancer and a germline BRCA1 BRCA2 mutation with more than or equal to 2 lines of prior platinum-based therapy, CR or PR on most recent therapy. So primary endpoint was investigator assessed PFS. Secondary endpoints was safety, tolerability, OS, PFS2, health-related quality of life, etc. Next slide, please. So as if we look at investigator assessed PFS, the graphs have moved apart very early and at a huge level. So hazard ratio was 0.3, 70% reduction in chances of progression. Next slide. Final analysis of SOLA 3, olaparib versus physician choice single agent non-platinum chemotherapy in germline BRCA mutated progressive ovarian cancer. If we talk about, so there was a significant improvement in overall response rates with a significant p-value, and a median PFS was also better as compared to chemotherapy. Patients with high-grade serous ovarian cancer, endometrioid or primary peritoneal and or fallopian tube cancers who were germline BRCA1, BRCA2 mutated, disease progression of more than 6 months after last platinum-based chemotherapy, at least 2 prior lines of platinum. Olaparib 300 mg twice daily per oral, investigator choice, and until progressive disease it was given. Primary endpoint was overall response rate, and secondary endpoint was PFS2 and OS. Next slide, please. Next slide. So final analysis, if we can see, previous slide, please. So if we look at the OS, so OS could not be very much better with DAO. Numerically, it was better, but the hazard ratios were not good. And if we talk about PARP inhibitor at the first subsequent therapy, it was used in approximately 3% of the patients. And next slide, please. PFS2. So it was able to provide a better PFS when analyzed later on. So hazard ratios were 0.8 with a 20% reduction in chances of uh, progression of the disease. PFS2 favored olaparib versus chemotherapy. Next slide. So if we look at other parameters, as we can see, the graphs have separated and the hazard ratios are really very good. It has been important secondary efficacy endpoints and have been found to be statistically also significant. Next slide, please. So final analysis of SOLO 3 safety summary. If we talk about, olaparib was good enough to be considered safe as compared to what benefits it's providing. So those interruptions were now high, as we also see that the same in clinical practice, and it was almost 50% at final OS analysis in olaparib and only 42% with chemotherapy. Those reductions due to adverse events was also seen in a higher number of patients who received olaparib, and treatment discontinuation was also higher with olaparib. Next slide, please. Final analysis of Solo 3, if we talk about, then grade 3 side effects were obviously more with olaparib, especially nausea, anemia, fatigue. These were higher when compared to the chemotherapy. Next slide, please. So now coming on to the next molecule, that is rucaparib in ovarian cancer. Next slide. So Athena Mono, this was the first trial, maintenance rucaparib versus platinum after first line of chemotherapy. So it was actually a multi-arm study. Adults with newly diagnosed stage 3, stage 4 grade, high grade epithelial ovarian cancer, fallopian tube or primary peritoneal cancer completed cytoreductive surgery, completed 4 to 8 cycles of first line platinum doublet chemotherapy, more than 4 cycles of platinum taxane, achieved investigator assessed response, sufficient tumor tissue available for central testing. Only then the patients were actually randomized in the 4 arms as mentioned. And arm A was rucaparib 600 mg per oral BID with nivolumab 480 mg Q4 weekly. Arm B, rucaparib 600 mg per oral BID versus placebo. Arm C was placebo versus nivolumab. Arm D was placebo BID versus placebo IV. So plus with this. So study analysis of Athena Mono, what we need to see at was arm B versus arm D. So arm B was rucaparib with placebo versus placebo. So this is the current analysis, and arm A versus arm B had also been looked at, but we are primarily concerned with this at present. So 24 months or until radiographic progression. Primary endpoint was again investigator assessed PFS. Secondary endpoint was OS, investigator assessed overall response rate. DOR, DICR assessed PFS safety. Next slide, please. So investigator assessed PFS in HRD population, if we see, then obviously there was a huge difference, as it can be very well be visible in the graph. So hazard ratio was 0.47, a 53% reduction in chances of progression in HRD positive population. So rucaparib maintenance significantly prolonged the investigator assessed PFS versus placebo in HRD population. Next slide, please. Now, investigator assessed PFS in intention to treat population. If we see again, the graphs have beautifully separated. So, rucaparib maintenance significantly prolonged the investigator assessed PFS versus placebo even in ITT with a 48% reduction in chances of disease progression. Next slide. Now, investigator assessed PFS in HRD positive and negative population. So, if we look at the negative population, even in that case, rucaparib had been useful. Uh, in HRD positive, obviously, the difference was huge and the delta was high. And in BRCA wild type, with loss of heterozygosity being high, there also the differences were good. Investigator assessed PFS benefit was observed with rucaparib independent of BRCA and HRD status. Similar results were assessed in BICR assessed PFS. Next slide, please. So most common, if we talk about the side effects, again, nausea, asthenia, fatigue, anemia, and increased AST, ALT, all these were the most common side effects. And these were obviously higher in the patients with rucaparib, uh, uh, ma- had to be properly managed in the clinics. Next slide, please. Next trial comes Ariel 4, rucaparib versus chemotherapy in advanced or relapsed ovarian cancer with deleterious BRCA1, BRCA2 mutation study design. Here also patients with relapsed high-grade epithelial ovarian, fallopian tube or primary peritoneal cancers with more than 2 previous chemotherapy regimes, including more than one platinum-based regime, deleterious germline or somatic BRCA mutation, no PARP inhibitor or single-agent paclitaxel treatment. So here the patients who were platinum resistant interval was assessed and rucaparib was given accordingly. In patients who were resistant at 1 month, so and they were actually randomized, and a follow-up of 28 days after the last treatment until radiologically confirmed disease progression, unacceptable toxicity, death or termination of the study. Primary endpoint was investigator assessed PFS. Median PFS was 7.4 months versus 5.7 months, and the hazard ratio was 0.67, which was good. This analysis pre-specified secondary endpoint analysis was OS in intention to treat and population, and exploratory analysis included OS in certain subgroups. Next slide, please. So if we look at the OS in intention to treat analysis, rucaparib could not provide any OS advantage. Next slide, please. So if we look at the platinum resistant versus partially platinum sensitive versus fully partial platinum sensitive, then the hazard ratio were not in favor of rucaparib when compared in platinum resistant, and not a very good hazard ratio could be achieved even in partially platinum sensitive, though it was not even good in fully platinum sensitive disease. Next slide, please. OS in intention to treat population adjusted for crossover, if we talk about, which is an important thing, excluding the patient who crossed over from chemotherapy to rucaparib. There, obviously, hazard ratios improved. And sensing the data at crossover from chemotherapy to rucaparib, if we talk about, even in that case, the hazard ratios were not at all good. So, time adjustment for OS covariate showed no difference between the treatment arms. Next slide. PFS2 subgroup by platinum status. Again, there was not a very significant difference. Next slide. So PFS during first subsequent anti-cancer treatment in platinum-resistant disease, randomized to rucaparib or randomized to chemotherapy, and then again first subsequent treatment after randomized rucaparib or crossover. We can see that PFS events during the first subsequent treatment after randomized rucaparib were reported by the investigator and included non-radiological progression. That was not a very huge difference if we can see on this on this. Next slide, please. Next slide. So safety analysis, again, adverse events were almost of the similar tune in both the arms, and anemia was more pronounced with the anemia, nausea, asthenia were more pronounced with the use of rucaparib, and a total of 3% of cases developed MDS AML and who were randomized to rucaparib, with 4 reported during the long-term follow-up. No cases were reported among patients initially randomized to chemotherapy. Next slide, please. Thank you.
Thank you, Dr. Shreyas Kirti, for such a informative talk. And we have 2 questions for you. The chat box.
Yes.
Are these questions visible to you?
Yes, sir. Yes, sir. Yes, sir.
Can you briefly take up those questions? Then we'll move on to the next. So, what is the timeline to start the adjuvant olaparib after finishing the chemotherapy? Is there any time frame where we can start, or can be started after
It
2 to
can be
3 weeks
started
of the
immediately.
patient?
There is no as such timeline for the same.
So once the patient is off this side effects from the chemotherapy after 2 to 3 weeks and fit enough to start on the next line, we can always put on the olaparib therapies. So if the patient progresses after 1 year, then how to go about it?
On PARP inhibitor, if the patient progresses on PARP inhibitors of last platinum, what should we do? So it's a platinum sensitive disease as such. Obviously, PARP inhibitors haven't made a very great difference. So in that case, platinum should be reused, and patient should be rechallenged. If bevacizumab has not been used in the first line, then bevacizumab can be added in such a scenario.
Right, right. Thank you so much. So now we'll move on to the next talk, and I would like to invite Dr. Ankur Nandan Vashne. Dr. Ankur, please. And Dr. Ankur is the consultant medical oncologist from Vedanta Gurugram. And he's going to give us talk on the triple negative breast cancer, diversity and clinical implications.
Hi, Dr. Chaudhary, sir. Thank you, and thank you for giving me opportunity. Just one question: are the slides moving, and is it visible to everyone?
Yeah,
Yes,
they are
sir.
much visible and moving.
Oh, thank you. So I think we have a certain delayed in our time. So I will try to cover it fast. So the topic given allotted by Dr. Chaudhary to me is covering the role of immunotherapy and chemotherapy as a part of neoadjuvant therapy in triple negative breast cancer. So I just start about the epidemiology of triple negative breast cancers. And in India, it has been reported that TNBC cancers made approximately 30% of all invasive cancers. And this incidence of triple negative breast cancer is higher in younger populations, which tells us about how important our subject is today. So majority of the patients who have age less than 35 years, they had a higher incidence of getting triple negative breast cancers. And in this patient population, approximately 76% of the breast cancers are triple negative breast cancers. So this accounts for approximately 20% of all breast cancers worldwide. And majority of these TNBC tumors are basal-like or Claudin-low if we go with the genomic analysis. Their patterns of gene expressions are quite heterogeneous, and this heterogeneous nature leads to lack of an effective treatment in this subtype of breast cancers. However, there are recently new advantage and therapeutic opportunities which we will study now. So coming to the survival of TNBC patients in India, the main thing is survival is quite low with the use of triple negative breast cancers. And if this triple negative breast cancer is caught early in the initial stage, that is in stage 1 to 3, patient has a 60% of chance of surviving 5 years. However, if this cancer is diagnosed in the metastatic setting, then we have the limited treatment outcomes. And in this setting, then the outcomes are limited, and 2-year overall survival is very low. So patients with triple negative subtypes are quite younger and more likely to be premenopausals, and these are usually presenting in the locally advanced stage with a higher proportion of node positive as compared to their non-TNBC counterparts. If we see the patient profiles of the triple negative patients, we see that majority of these patients are premenopausal, and duration of lump history has been reported approximately 6 to 7 months. Family history is positive in them. They mainly carry the BRCA genes. And nodal positivity is significantly higher. If we see nodal positivity in TNBC, it is approximately 60%, while in the non-TNBC subgroup, it is only 43%. Majority of these patients are diagnosed in either stage 2 or stage 3. Upfront surgery is possible in approximately 38% of patients, and breast conserving therapy with the use of neoadjuvant therapy is approximately possible in approximately 40% of these patients. So, coming to the use of rationale for NSAT in TNBC, chemotherapy is recommended for women with TNBC who have a tumor size of greater than 0.5 centimeter or either lymph node positive, regardless of the tumor size. So, these patients have a higher risk of relapse compared with the other breast cancer phenotypes. And as these are triple negative, we cannot give any targeted therapy to them, neither the hormonal therapy. So if patients who receive this neoadjuvant chemotherapy and achieve pathological complete response with the use of chemotherapy, this is associated with significant improvement in disease-free survival. If patients who have presenting with a very smaller disease, which is T1C less than 1 centimeter, also these can be offered neoadjuvant therapy, and these might receive additional treatment if residual disease is identified as shown by the CRIT extra. So what chemotherapy we have used, we have still in the chemotherapy which have been defined in the breast cancer includes the combination of an anthracycline and the taxane-based chemotherapy, which have been the standard of treatment for every breast cancer case, particularly significantly in the TNBC cases. However, non-anthracycline-based regimes can be used in a lower proportion of patients who have a lower risk, which are node negative, have less than 1 centimeter, or in case if the patient is having a cardiac risk factor, the anthracyclines has to be avoided. So the first significant improvement in the recent advances in the TNBC includes the use of neoadjuvant carboplatin in the TNBC, and this is supported by this study which is published in the ESMO, and this is a survival analysis of adding carboplatin to the already existing anthracycline taxane-based neoadjuvant chemotherapy and the HRD score, which is used as a predictor of response. So we see in this study, patients were randomized to receive either paclitaxel plus non-pegylated liposomal doxorubicin or pegylated with the combination of carboplatin. The secondary endpoint of this study was DFS and OS, and they have used the homologous recombinant deficiency as HRD score of 42 or presence of tumor BRCA mutations as a for the patients who are eligible for the PARP inhibitor maintenance. So the outcomes of this study shows that the addition of carboplatin showed a significant better DFS benefit as compared to the patients in which carboplatin was not used. If we see this as compared to the when we divide the patient cohort into the HR deficient, HR non-deficient, we see the benefit of addition of carboplatin was achieved in both the subgroups. And PET-CR was achieved in approximately 55% of patients in the HR deficient group with the addition of carboplatin, while it was 50% in the subgroup where carboplatin was not added. So we see the addition of carboplatin to the initial therapy increases the PET-CR rates from 33% to 63% in HR deficient tumors, while DFS rates were improved with the addition of carboplatin both in HR non-deficient and HR deficient tumors. So the study concluded that addition of carboplatin to the neoadjuvant chemotherapy improve the DFS benefit. Long-term survival analysis data supports the use of neoadjuvant chemotherapy of carboplatin in the TNBC arm. HR deficiency in TNBC and HRD scores are predictor of response, but they doesn't predict the carboplatin benefits. So carboplatin should be given both the patient, either they have BRCA positive or BRCA negative. This is one more study where dose dense protocol was studied with the use of carboplatin, and we see in the patients were either early breast cancers, which were hormone receptor and HER2 receptors were negative. Patients were randomized to receive apirubicin followed by taxanes, followed by cyclophosphamide every 2 weekly or weekly protocols, and HER2 positive breast cancers received trastuzumab and pertuzumab. So the outcomes of the study was PET-CR rates were increased with the use of dose protocol. With the combination, the benefit was achieved in 48% patients versus the patients who didn't use the protocol. The PET-CR rates were quite poor in them. And this study concluded in patients with a high-risk breast cancer, there is no significant difference in PET-CR rates achieved following neoadjuvant therapy with dose dense if the combination of carboplatin was studied, and effective dose dense regimes are still quite feasible in our day-to-day practice and should be preferred. So to summarize the use of carboplatin in NSCT, we have 3 randomized trials which have constantly demonstrated the advantage of improving pathological complete response rates with the addition of carboplatin to the paclitaxel and anthracycline containing neoadjuvant chemotherapy regimes. Though none of these studies were designed to determine the impact of carboplatin on long-term outcomes, 2 of these studies have reported significant improvement in the event-free survival with the addition of carboplatin. Till now, there is no randomized trial which has directly compared every 3 week and the data for every 3 week and weekly carboplatin when administered with weekly paclitaxel during the neoadjuvant therapy. Both patients who carry a germline BRCA mutation carrier and germline BRCA wild type with TNBC are more likely to achieve PET-CR with the addition of carboplatin as a part of neoadjuvant therapy. And we see the patients who are without a germline BRCA mutation carry a much larger increases in PET-CR rates as compared to the BRCA patients, which is quite contrary to expectations. And magnitude of improvement in event-free survival with the addition of carboplatin didn't differ in the patients who are BRCA mutated or who have BRCA wild type. So with the changes in the chemotherapy, now we move with the new changes in the neoadjuvant treatment, which includes the use of immunotherapy. And if we see the immunotherapy, we had many trials, out of which neoadjuvant trials include the Keynote 522 study, where we study the combination of carboplatin with paclitaxel with the use of pembrolizumab. We have NSB-ABP study, where the use of atezolizumab was studied. Again, the IM patient studies where atezolizumab was used. New trip PD-L1 trial where atezolizumab has been used. And in the adjuvant data, we have the impatient and SWAG study where adjuvant immunotherapy has been read. So, what is the role of immunotherapy in patients with TNBC? In patients with TNBC, we see increased presence of this tumor infiltrating lymphocytes as compared to the other tumors, other breast subtypes which are ER positive and HER2 positive. So, resulting in these tumor have a high PD-L1 expression as compared to the non-TNBC breast cancers. And if we see the other presence of other non-serous mutations, as we have already discussed in the initial slides, this triple negative is a heterogeneous disease, and more significant mutations are present in the TNBC cohort as compared to the HER2 positive or luminal A or B cohort. So, depending on these mutation profiles, majority of patients in the TNBC arm presenting with a high PDL1, and this is the high PDL1 scoring. PDL1 scoring we do either based on the combined positive test, which is called a CPS score. Then TPS score is total positivity score, and either IC which is the PDL1 percentage. So, what we have seen with the phase 3 trials, that with the addition of pembrolizumab arm, we see the estimated PET-CR rates have increased to 60% as compared to the control arm, where PET-CR rates were only 22%. And this benefit has resulted in constant EFS benefit in the pembro arm. A number of studies have investigated the impact of addition of immunotherapy to the as a part of NSCT. However, pembrolizumab is the only successful drug which has concluded a phase 3 study showing a longer term benefit and has received FDA approval in this setting. The other agents, which includes the atezolizumab and durvalumab, they are still investigation. So we see the resultant trial where on which the basis of trial the pembrolizumab as a part of neoadjuvant protocol was approved, and this is a Keynote 522 study where patients greater than 18 years with newly diagnosed TNBC breast cancer, either T1C or the presence of lymph node, which was N1, N2, or T24 with the presence of lymph node, were included in the study. These were PD-L1 testing was done in both the patients, and then these patients were randomized in the ratio of 2:1 to receive 4 cycles of paclitaxel carboplatin plus pembrolizumab 200 milligram every 3 weekly in the initial setup, and later 4 cycles of either doxo or epirubicin plus cyclophosphamide along with pembrolizumab. The chemotherapy arm was same in the placebo control arm, and after the completion of 8 cycles, we see the patients were taken for the surgery. In the adjuvant phase, the pembrolizumab was continued every 3 weekly for the 27 weeks. However, in the placebo control arm, no further maintenance was given. The primary endpoint of this study was defined as the PET-CR rates and EFS by the local review, and secondary endpoint was OS and adverse event analysis. We see the baseline characteristic. The patients are quite young. Majority of the patients were, the median age reported were 49 in the pembrolizumab arm and in 48 in the placebo control arm. Majority of the patient, as reported, were premenopausal. PDL1 was positive in approximately 80% of this patient population. They have a preserved performance status. And if we see the carboplatin arm, carboplatin was given weekly in majority of the patient in this study, and the majority of the patients were lymph node positive. So majority of these patients were defined as stage 2. If we see the results, the primary endpoint, the best CR achieved in the pembrolizumab arm was 64%, while best CR with the use of either chemotherapy alone was 51%. So we see with the addition of pembrolizumab arm, best CR was increased in the 14% of the patients. If we see this with the PDL1 positive status, so the patient population who were PDL1 positive, PET-CR was achieved in 68% of the patient population in the pembrolizumab arm and 54% in the placebo control arm. If we see the PDL1 negative patient population, this difference was quite significant still. And PET-CR was achieved in 45% of the patients who were PDL1 negative with the use of pembrolizumab arm, while it was achieved in only 30% of patient population in the placebo control arm. So if we see the difference, the benefit of pembrolizumab was persistent irrespective of the PDL1 score. Coming to the benefit of EFS, we see 18-month EFS was reported in approximately 91% of patients in the pembrolizumab arm and in 85% of the patient population in the placebo control arm. So at a longer follow-up, the data which was presented at the ESMO conference, the addition of pembrolizumab also improved 36-month EFS comparative to 85% with the use of pembrolizumab arm and 77% with the placebo, with a significant 37% reduction of the events. The absolute EFS benefit with the addition of pembrolizumab was still larger in patients who failed to achieve the PET-CR with the use of NACT as compared to the patient who achieved PET-CR. So with the addition of patient who achieved PET-CR, the EFS was reported as 94% versus 92%. So EFS improvement was seen in both PDL1 positive and PDL1 negative subset and did not differ by the chosen schedule of carboplatin, which was administered either weekly or 3 weekly. So node negative patient had superior outcomes as compared to the node positive patients, irrespective of whether they have achieved the pembrolizumab arm or not. But there was significant benefit in the EFS reduction was noted in the patients who had node positivity. The magnitude of benefit of adding pembrolizumab arm was similar across all the cohorts, and there was a numerical benefit with the improvement in overall survival. We see at the end of 3 years, the OS benefit with the use of pembrolizumab arm was 90%, and with the use of placebo, it was only 87%. However, this difference is whether it is statistically significant or not, we cannot tell it right now, and data is quite immature for this endpoint. But as we have earlier seen in many studies where PET-CR had definitely resulted in the longer EFS and OS benefit, and we have seen a significant PET-CR benefit with the use of pembrolizumab arm. So this can be likely giving us OS benefit with the use of longer follow-up. So now comes the adverse events. What adverse events were reported? So adverse events were any grade were reported in approximately 99% patient population pembrolizumab arm and approximately 100% patient population in the chemotherapy arm. So the most common side effects with the use of this combination were nausea, alopecia, anemia, neutropenia, as were reported in all the in both the control as well as pembrolizumab arm, and we see the data was quite similar in both the arms. If we see the most adverse event of interest, which were the quite immune related, so we see infusion reaction was documented in 16% of patient population in the pembrolizumab arm, while they were reported in only 11% of patient population in the chemotherapy arm. Hypothyroidism was reported in 13% of patient population as expected. These are quite higher in the pembrolizumab arm, while in placebo only 3% of patient population reported hypothyroidism. Adrenal insufficiency was reported in approximately 2.3% patient population in the pembrolizumab arm, while non-adrenal insufficiency was reported in the placebo control arm. So what we achieve that grossly side effects are quite similar with the as majority of side effects are because of chemotherapy. However, immune-related adverse events were reported in approximately 50% of patient population. However, grade 3 adverse events were reported in less than 4% of patient population. So the investigator concluded in patients with early stage triple negative breast cancers, neoadjuvant pembrolizumab plus chemotherapy is associated with a larger PET-CR benefit, especially in patients for stage 3 or node positive disease. Benefit is seen especially patients who have received less than the planned full chemotherapy doses, and this benefit was observed regardless of the PD-L1 expression levels. So neoadjuvant pembrolizumab added to the chemotherapy is associated with the higher rates of lower residual cancer burden. So rates of adverse events which are immune mediated is consistent with the all previous existing studies, and additional studies are needed to confirm long-term EFS and OS benefit. So now we will study the other immunotherapies which have been studied with the breast cancer, and the other study have been studied is atezolizumab in the IM patient study, and the similar atezolizumab was combined with the nab-paclitaxel with every weekly with the doxorubicin and cyclophosphamide, followed by surgery, followed by maintenance atezolizumab, and again the nab-paclitaxel was used in the patient population who had not received, who had received placebo. Primary endpoint of this study was again PET-CR, and a secondary endpoint was DFS and OS benefit. So if we see the data results of this study, PET-CR was reported in approximately 57% patient in the with the use of atezolizumab with chemotherapy, while it was reported in 41% of patient population with the use of only chemotherapy. So the difference is 16.5%, and with the addition of atezolizumab, approximately 16% patient achieve more significantly PET-CR. If we see this difference with the PD-L1 positive and PD-L1 negative, the results are quite as was expected. In PD-L1 positive patients, with the use of atezolizumab, 68% patient achieved PET-CR in the immunotherapy arm, and 49% achieved PET-CR in the chemotherapy arm. The difference of PET-CR was approximately 20%. While in PD-L1 negative, PET-CR was achieved in 47% of patient population in the immunotherapy arm and 34% patients in the chemotherapy arm. The difference of PET-CR was only 13%, and we see that with the use of atezolizumab, patients who are PD-L1 are significantly deriving more benefit of the immunotherapy. The IM patient study concluded that the addition of atezolizumab to the neoadjuvant chemotherapy had increases the overall PET-CR rates, and PET-CR rates were improved in both PD-L1 patient and PD-L1 negative patients. Early results of the EFS are quite promising, but this study was not powered to address this issue. And new TRIPA study, where atezolizumab was again used, failed to show any increase in the PET-CR rates with the addition of atezolizumab to chemotherapy, where in the neoadjuvant chemotherapy, carboplatin was also considered with the nab-paclitaxel. In the IM patient studies, only nab-paclitaxel were used and carboplatin was not used. So whether carboplatin plays any significant role is need to be studied. So coming to the next drug, the next immunotherapy drug which have been studied in the breast cancer includes the durvalumab, and we have a GEPAR Nuvo study, which is German study. Approximately 174 patients were included in this study, and patients were randomly assigned to receive nab-paclitaxel followed by epirubicin cyclophosphamide with the addition of durvalumab in the test arm and placebo in the control arm. With the study concluded with the addition of durvalumab, there is a numerically increased PET-CR rates in the patient, which is quite comparable in both PD-L1 positive and PD-L1 negative cases. However, the difference doesn't reach any statistical significance. And out of 117 patients who participated in this treatment, a single dose of their assigned study drugs 2 weeks before starting NSCT received durvalumab had a significantly higher PET-CR rates, which suggests a role of immune priming in these patients. So after a follow-up of 42 months, the addition of durvalumab improved 3-year invasive DFS as compared to 86% in the test arm compared to 77% in the control arm. And this improved DFS is changing to OS benefit also, but the concept of window treatment, which was immune priming, is not quite studied. And we see the addition of immunotherapy to the NSCT and TNBC draw conclusions of effectivity of this agent as compared to the other drugs also. I conclude. Thank you. If there are any questions, I will be pleased to answer.
Thank you, Dr. Ankur, for such a elaborative talk. And if there are any questions, we can take one question. I think the presentation was so clear that there are no questions.
So I will like to conclude the one thing.
We'll move on to the next and the last. Thank you, Dr. Ankur.
Okay, thank you, sir.
So we'll move on to the next talk. And for that, I would like to invite Dr. Pooja Babbar. Dr. Pooja is a consultant medical oncologist at C.K. Birla Hospital in Delhi. And Dr. Pooja is going to deliver a talk on a flexible future transforming the paradigm of HER2 positive breast cancer treatment.
Wow.
Dr. Pooja, please.
Hello, sir. Good evening. Thank you, Dr. R.K. Chaudhary, sir, and Roche for providing me this opportunity. And I would like to share the screen, but I think you cannot share screen while other participant is sharing. So I hope my slides are visible.
Yes, ma'am.
Yeah, they are
Okay.
visible.
So the topic for today's talk is transform the journey for your HER2 positive breast cancer patient. So these slides are provided by Roche. So Perjeta Herceptin has transformed the treatment landscape, and it is the standard of care for patients with HER2 positive breast cancer. As we have seen, either in the neoadjuvant setting, adjuvant or metastatic setting, the role of pertuzumab has very well been established. Coming to the neoadjuvant, there is a pivotal study, Neosphere, where we have seen the addition of pertuzumab to Herceptin plus chemotherapy has actually improved the PAT-CR from 31 to 50% as compared to Herceptin plus chemo. And certain additional supporting studies being Trifina, where we have seen that TCHP regimen has shown PAT-CR rate up to 65%. Coming to the adjuvant setting, early breast cancer at high risk of recurrence, that is either node positive or more than 2 centimeter, addition of pertuzumab has shown to reduce the risk of recurrence and death by 23%. And especially in node positive, the benefit is even higher. 3-year disease-free survival benefit increased from 83 to 88%, that is close to 5%, with a relative reduction in the risk of recurrence by 28% as compared to single-agent anti-HER2 therapy plus chemo. Coming to the metastatic setting, a famous Cleopatra trial, which is also the first line in HER2 positive breast cancer, the addition of pertuzumab has increased median progression-free survival from 12 months to 18 months, whereas the OS increased to 56 months from 40 months. So this concludes that Perjeta Herceptin is approved and recognized as the standard of care for HER2 positive breast cancer. Again, explaining the same, any patient with newly diagnosed HER2 positive early breast cancer. So whenever the tumor which is HER2 positive, more than 2 centimeter node positive, neoadjuvant strategy is giving chemotherapy plus pertuzumab and trastuzumab. After surgery, if there is a PAT-CR, we can continue the dual anti-HER2, or if there is a residual invasive disease, can continue TDM1 up to 14 cycle, as we have seen in Cadzilla trial that there is an 11% DFS advantage. Early stage CT1, that is less than 2 centimeter. Post-surgery, we have an APT regimen, which has shown very good 3-year disease-free survival up to 98 to 99%. And in node positive, again, being a high risk, we have to continue dual anti-HER2 with chemotherapy and continuing the HER2 therapy till 1 year. Now, what are the challenges of IV infusion of pertuzumab and trastuzumab? So pertuzumab is infused over 60 minutes followed by observation. So there's a long infusion and observation time. IV preparation is also longer as compared to subcutaneous, plus we would require indwelling venous access that actually increases the risk of infection, thrombosis, and discomfort. Establishing IV access is also burden for patient with poor venous access. Now, Phesgo is the first formulation in oncology to combine two anti-HER2 therapy, pertuzumab and trastuzumab, in one vial for subcutaneous administration. So, Phesgo injection contains the same antibodies, the same drugs as used in IV pertuzumab and trastuzumab, but definitely the route of administration is different. The route of administration is subcutaneous. It is specifically formulated with recombinant human hyaluronidase so that a subcutaneous administration can be allowed, because for the loading dose we give 15 ml and for the maintenance we give 10 ml. To give this much ml via subcutaneous administration require the breakage of hyaluron so that the drug can be assimilated in the subcutaneous tissues. So it is formulated with recombinant human hyaluronidase. It is a ready to use, it's a fixed dose combination administered by subcutaneous, whereas we administer loading with 8 minutes and then maintenance by 5 minutes. The mechanism of action of PER2 and trastuzumab fixed dose combination. PER2 and Trastu fixed dose combination use both these drugs with human hyaluronidase. As we know, pertuzumab blocks HER1 and HER3 dimerization, and it provides an additional dual blockage of HER2 signaling pathway. Hyaluronidase is used to increase the absorption and dispersion of co-administrated drug. What hyaluronidase does, it allows subcutaneous delivery of large drug volume. Since for the loading we use 15 ml and for maintenance we use 10 ml. So by depolymerizing the hyaluron, it increases the permeability of subcutaneous tissue, and those effects are also reversible, and the permeability of the subcutaneous tissue is also restored within 1 to 2 days. Now, what is the impact of this recombinant hyaluronidase on subcutaneous injection of large IV, large fluid volume? The subcutaneous layer contain hyaluron, and as we can say that, as we can see in this pictorial representation, that by addition of this, it locally degrades hyaluron at the injection site, but there is no major change in macromolecules being collagen and elastin. By degrading those hyaluron, you increase the dispersion so that you can administer large volume easily. And the architecture of skin is again reformed in 1 to 2 days, because this hyaluronidase is rapidly cleared, and it also does not modify the major macromolecules. And as we can see, because of this hyaluronidase, we can administer subcutaneous administration up to volume which is larger than 1 ml, because we use 15 and subsequently 10 ml. So does Phesgo fixed dose combination subcutaneous have the same pharmacokinetics, efficacy, and safety as pertuzumab plus Herceptin IV? So initially, Phesgo clinical development programs were designed to find the dose of pertuzumab that has to be used within Phesgo, and that was a phase 1b trial which established that the loading dose of pertuzumab would be 1200 and trastuzumab would be 600, followed by a maintenance 600-600 fixed dose combination. There were certain studies to establish pharmacokinetics, efficacy, safety, and preferences. Federica is a phase 3 trial to analyze the pharmacokinetic efficacy and safety, and Ferencia's is a trial to evaluate the preference of patient in terms of whether IV or subcutaneous administration. So this is a dose finding study, which I would not go into detail, but it actually used different cohorts with different doses of pertuzumab, and it compared it with standard Perjeta IV dose. And after this study, it was established that a loading dose of 1200 of pertuzumab and maintenance dose of 600 would be required. And there were no new safety signals which were observed for pertuzumab subcutaneous. Now, Federica, that is the fixed dose combination of pertuzumab and Herceptin trial. It was a phase 3 non-inferiority study to assess the pharmacokinetic efficacy and safety of Phesgo versus IV Perjeta. So these were patients with operable or locally advanced inflammatory HER2 positive breast cancer. Basically, the patient who are more than 2 centimeter or node positive. They were randomized into arm A and arm B. The chemotherapy choice being dose dense AC, 2 weekly 4 cycle or 3 weekly 4 cycle, and both the arms were similar, followed by combination of Herceptin and pertuzumab IV with paclitaxel, where paclitaxel was given weekly for 12 cycle and 3 weekly docetaxel for 4 cycle. Whereas in the arm B, fixed dose Phesgo subcutaneous injection Q3 weekly into 4 cycles were given, either with Pacli weekly for 12 cycle or docetaxel 3 weekly for 4 cycle, followed by surgery and followed by this schedule of IV pertuzumab plus Herceptin versus Phesgo continuing up to 1 year, followed by a follow-up. So the primary endpoint was non-inferiority of cycle 7 serum concentration trough level, and the secondary endpoint being non-inferiority of cycle 7 serum trough level, PAT-CR, and safety profile and other outcomes. So as we can see, pharmacokinetics are important to understand the bioequivalence of IV and subcutaneous administration. And we can see the C trough levels, that is the trough plasma by serum concentration. So that is the lowest concentration which we achieve, before starting the next cycle, which is associated with clinical outcomes. Then we have AUC, which is the area under plasma by serum concentration, whatever drug the patient has exposed during a particular cycle. And Cmax is the peak plasma by serum drug concentration, which has no clinically correlation with outcomes. And we can see this is the IV and this is the subcutaneous, where there is a difference in Cmax, IV being more and subcutaneous being slightly low because of the additional time required for absorption and elimination, but that does not correlate clinically with the outcomes. And we can see a very good levels and comparable levels achieved with subcutaneous administration. And before the next administration, C trough, that is the lowest level in the plasma, is also quite comparable. And then this is the same slide which is depicting the serum trough level, which is 72% for IV and 88% for subcutaneous. As we can see in this graph, that the C trough of subcutaneous is slightly more, and secondary endpoint being H serum C trough, which is also comparable, which is also more in subcutaneous administration, being 57.5% as compared to 43%. So which is non-inferior or maybe comparable. Now coming next to the outcome, which is the most important parameter when we give neoadjuvant therapy, especially in HER2 positive breast cancer, which is PAT-CR. And as we can compare IV versus subcutaneous, it is quite comparable. Also by body mass index, because the Phesgo which we are giving is a fixed dose combination, which does not depends on body weight. Still, if we see this blue bar, the results are quite comparable. And coming to the safety profile is quite comparable in terms of grade 3 and more serious adverse events, or death and discontinuation is also quite comparable. And most common adverse event was quite well balanced. Diarrhea being one of the most common side effect which we see, and it is 55% in IV versus 58% in subcutaneous. So incidence of adverse events were also consistent with the IV study. And coming to the hypersensitivity, cardiac dysfunction, and adverse or infusion related reaction between the arms, as we can see, the blue bar, which is of Phesgo, and the pink bar, which is for IV. For the diarrhea also, it is quite comparable. For neutropenia, also comparable. Cardiac dysfunction, quite comparable. though infusion-related reactions are slightly more as compared to IV administration, and rest serious adverse events are also quite comparable. So there was no meaningful difference in cardiac safety between both the treatment arm, as we can see that there are no severe adverse event related to cardiac dysfunction in the Phesgo arm. It was 2% in the LVF decline versus 2.8% in IV. So quite comparable again in cardiac safety parameters. So the conclusion is of the study is that Phesgo subcutaneous is non-inferior to IV based on serum levels, based on PATCR rates, and it is quite consistent with the previous trials of IV pertuzumab and trastuzumab. Safety profiles are also consistent and no new safety signals have been identified. So now the next trial is regarding, do patient prefer subcutaneous over IV? So this is the Ferencziska trial, which is a phase 2 study that assess patient preference. So here in this trial, patients with HER2 positive early breast cancer. Now these are the patients who have actually completed neoadjuvant IV formulation of pertuzumab and Herceptin with chemo, underwent surgery, and in the adjuvant setting, this trial has been done, where it is a crossover study where initially pertuzumab and Herceptin IV was given into 3 cycle in one arm, crossover to Phesgo in the next 3 cycle, and the second arm contained Phesgo 3 cycle, that is the subcutaneous administration, followed by IV formulation for 3 cycle, and then the next continuation up to 18 cycle, up to the remaining cycle of 1 year was dependent on what patient prefer, whether subcutaneous or IV formulation till the follow-up period. And here the primary objective was to establish the patient preference and also patient satisfaction and patient choice of formulation, health-related quality of life. So as we can see, all things considered, which method of administration do you prefer? And as we can see this blue bar. So the subcutaneous was preferred by 88%, 83%. So only 14% of the patient actually preferred IV, and the majority of the patient, close to 85%, preferred subcutaneous administration. And the main reason for subcutaneous was that less time is required. For loading, we need 8 minutes. And for maintenance, it is 5 minutes as compared to 1.5 hours. And it is more comfortable drug administration that does not require any IV access. So 87% chose Phesgo to continue treatment in the rest of the cycles to complete 1 year. More patients were very satisfied or satisfied with Phesgo versus the IV formulation, as we can see in this blue bar that the satisfaction rates was quite more in the subcutaneous administration. Treatment had no impact on patient HCP speaking time, and most patients actually had more than enough time to talk to their healthcare professional during treatment. So in the fixed dose subcutaneous administration, the time 90% of the patient had more time compared to 83% patient in IV formulation. So majority of healthcare professional also felt that switching from IV to subcutaneous actually save time and resources. So as we can see here that 15 to 20 minutes and for IV is required for, this is the time which is required for drug preparation in IV formulation versus 5 minutes for fixed dose. And then also there is a lot of difference between the administration time. So 88% of HCPs thought that it is the quickest from start of preparation to completion. And since it is a ready to use, so it resulted in less drug wastage, and also it required less resource usage. Coming to the adverse event before and when you switch over. So it was quite comparable after you switch over, whether you switch from IV to subcutaneous or subcutaneous to IV, there was no major adverse event between both the groups. So 85% of the patient preferred the subcutaneous formulation, whereas 14 preferred the IV formulation. And as we know, the main reason is less time, more comfortable. More patients are very satisfied and satisfied. Though the treatment had no impact on the amount of time they had to talk to their doctors. And only while receiving treatment, they had more time to talk to the healthcare professionals. And HCPs indicate that it is quite time saving, require few resources. And regarding safety profile, it is quite well tolerated, consistent with the previous studies in terms of safety profile, no new safety signals, and the safety supports we have already seen with the previous Federica study regarding FESGO. So what are the practical consideration for using FESGO in the real world? So certain tips to ensure comfortable delivery. Ask the patient to sit in a reclining chair. Be sure to arrange your chair at the right level so that feet are flat. Ensure that your hands are in good position. The injection site should be altered between left and right thigh. It should not be administered in the abdomen. Do not split the dose between the two syringes, and each new injection should be given at least 1 inch away from the previous site. And always choose a healthy site which is not red, bruised, tattooed, tender, or hard, and record the used site to the patient note. Regarding how to administer the injection, you have to pinch the skin of the thigh with one hand so that you can create the fold, and keep the injection at 30-degree angle. If at any point during the injection patient feel uncomfortable, ease of the injection before continuing, and keep it at right 30-degree angle. Injection should be slowed down if the patient experience an injection related reaction, and it should be discontinued immediately if you have a serious hypersensitivity reaction like anaphylaxis. After loading dose, you should ideally wait for 30 minutes of observation for the signs of hypersensitivity symptoms. After the maintenance dose, the patient should be observed for 15 minutes to monitor the signs of hypersensitivity symptoms or infusion related reaction. Best practice is setting aside hospital space for administration of fixed dose combination for subcutaneous use. And what would FESGO mean for patient and HCPs? So in a nutshell, it provides benefit in terms of cost, time, and reduction of patient and HCP burden. So the advantages being shorter administration time, ranging from 8 minutes in loading and 5 minutes in maintenance. Also the observation period being 30 minutes in the loading and 15 minutes for the maintenance of FESGO, that reduces the burden on caregivers and providers. FESGO has a less invasive administration, being a single subcutaneous administration that reduces the burden of IV-related pain, bruising, and irritation. Fixed dose formulation also helps to reduce dosing error, dose wastage, and it increases the availability of staff for other tasks. It also reduces the time which is required for drug preparation and administration as compared to the IV. And no new safety signals has been observed when we switch from IV to FESGO and vice versa. So in a nutshell, FESGO is the first formulation combining two monoclonal antibodies in one vial of subcutaneous administration, less invasive, more faster in terms of pharmacokinetic, as we have seen the trough concentration was quite comparable. As in terms of outcomes, in terms of PATCR, they were also identical. Also in terms of safety profiles, we have seen it is quite consistent. And also in terms of patient preference, 85% patient preferred FESGO as compared to IV formulation. And majorities of HCPs also thought that switching from IV to subcutaneous actually saved time, resources, and drug wastage during preparation and treatment. So in a conclusion, it is now an FDA approved for the same indication as IV. With or without concomitant IV chemotherapy. It is approved for neoadjuvant, adjuvant, and metastatic HER2-positive breast cancer. Thank you all, and thank you, Rosh.
So thank you, Dr. Pooja, for such a lucid and informative talk. And I don't think after such a beautiful talk, there will be any question left. So thank you so much.
Thank you, sir.
Thank you, Dr. Puja. So once again, very good evening to one and all, and good night to everyone. So with this, we are at the finishing line of this 2-day virtual conference, Oncology Insight 2.0. In the last 2 days, we discussed lung cancer on the day one, where our eminent speakers threw light on the burning topic of the targeted therapies in the lung cancer. On the day two, we discussed breast cancer in and out from the triple negative breast cancer complexities and HER2 positive breast cancer sequencing and the newer formulations. I really thank all the speakers for taking out time and for being the part of this academic feast. I also thank all the delegates for their patient hearing and contributing in the discussion. This kind of discussion was not feasible without support from our academic partners, so I would like to thank them one by one. Thank you, Rosh. Thank you, Lupin. Thank you, Freginus Kavi. Thank you, Mark. And thank you, Sanath. And thank you, Datar Cancer Genetic Limited. At the end of a very, very special thank to my technical support team and the organizing team for making this conference a great success. Thank you all. Thank you so much. And good night to all.
Thank you everyone for joining. Thank you. Good night. Take